Make him the host.
Is everybody seeing it?
Yep.
That is not the first slide, though, John. That's the third one. Yeah. There we go. Perfect.
Okay. Everybody knows David, of course, but he has invited a friend, Dan, who's going to join us and I think actually present a case. But Dan, why don't you give your background? And
Well, thank you, John. Um, I I was a congregational rabbi for 30 years. And during that time, I was also had the uh, privilege to work with some very skilled psychedelic facilitators, guides, and learned a great deal from them. And pardon? Yeah. And so I've been involved with a lot of end of life work and also psychedelic work as well. That's all I'll say for the moment. Um, I, I formed coming out of my work as a congregational rabbi, I formed a healing center here in the Bay Area that does a lot of education, a lot of grief work, support work, end of life work, and psychedelic education and facilitation.
excellent. Take it away, David.
Well, great. Thanks. And thanks, Stan, for being here. As with much of the learning, it really helps to have other elders in the room. Well, the impetus for today was I got asked to give grand rounds for Altobate's Herrick Psychiatry Department, and then a little more focused talk specifically around ketamine-assisted psychotherapy, because ketamine is really, other than cannabis, the only legal psychedelic, and certainly one that's gained a lot of attention here in the last couple of years. So that's going to be the focus of today. Next slide. Just my wife is a ketamine therapist as well as a mindfulness and LMFT. I belong to the Shulgin Farms, MAPS. We did form reimaginedying.com, which is focused towards end of life. And I do own some Compass stock. Okay, next slide. So this is a bit about what I hope you'll get out of today, which is understand how many people are using psychedelics, how often and why. Understand that only a small percent of those, probably 1 or 2%, are actually in therapeutic settings with a licensed or a skilled facilitator. There are FDA indications for ketamine, and there are off-label uses for ketamine. Want you to understand a little bit about psycholytic versus psychedelic therapy. There's debates about sort of how into and how high a dose you need to get the effects. There are also debates about how much of the psychotherapy is a contributing part. That was behind some of the MDMA controversy last year. Also, have you understand set and setting, which is Timothy Leary years ago, Aldous Huxley, but setter and substances. And then the next slide has a couple more objectives. I've been building a framework called Going In, and partly based on the two words IN, which will become clearer, and hope that'll give you some sense of what that involves. Contraindications and risks of ketamine, which are pretty minimal, but as we all know with Matthew Perry, one case can derail a whole movement. And then we're going to talk about several case examples, the second one of which is Dan's, and I will have him present that. Okay. Next slide. So I think we may have seen this before. What mind-altering substances have you tried? I'm going to include caffeine, alcohol, cannabis. I thought of having one where, anybody who's used any psychedelic in the last year should cover up their screen so we could get a visual of how many people have tried different things. But, these are all legal mind-altering substances and have uses and abuses, much like ketamine. So, why do you use them? And almost more importantly, how do you describe the experience? Because for psychedelic work, it's very the when we get to the cases I'll explain, we use the first journey oftentimes to just familiarize somebody with an altered state of consciousness. Because maybe somebody's been a little drunk or maybe somebody's been a little high with cannabis, but psychedelics are their own class. And I sometimes say it's a little like describing a rainbow to a blind person or a symphony to a deaf person. It's the words to use it and um, the value that one might get from it, or that some people would get from it, is sometimes hard to convey. What are our current standards of care for trauma, depression, and anxiety? Because, 40 years ago when I was training, 45, the SSRIs came out. Since then, ketamine is the only drug that's come out for depression. There's been almost nothing. And even the initial data on SSRIs is being put into question now. So we don't have a lot for these pretty, major impairing situations. Um, and those effective treatments are, you know, we'll discuss a little bit of them. And then I think the last one, there was a whiplash against many of the psychedelics started in the 70s by the Nixonian war on drugs. And the cat's back out of the bag a little bit, but the question remains, does curiosity kill the cat or open the mind? And I hope you'll get a little sense of that. Next slide. I think we're all pretty aware of, what's currently going on. And we had that talk, oh no, that was Grand Rounds about deaths of despair. But, the vets coming back with PTSD and suicide, 10 a day. Depression takes a tremendous toll on people in this country. COVID, of course, didn't help. And then the narcotic, mostly prescription narcotics, killing upwards of 80,000 people a year in the United States alone. So we have a mental health crisis and not a lot of great tools. Next slide. So this talk isn't about MDMA for PTSD or couples work. It isn't about LSD and its quite valuable role in alcohol addiction. Bill Wilson famously attributes a lot of his forming of AA to LSD. Cary Grant was probably the more famous person after, I think, 100 different LSD journeys was featured. It isn't about ibogaine for opioid, which is getting a lot of press in the South in particular, Tennessee, Texas. Several states have pumped tens of millions of dollars into ibogaine, and we'll discuss that briefly. And it isn't specifically about psilocybin for the end of life. I'm trying to focus on ketamine, though one of the things that's clear is that all of the psychedelics have overlapping and relatively similar impacts, which are incredibly different from the SSRIs or the opiates or the benzodiazepines, most of which placate people's symptoms but don't deal with underlying causes. Next slide. So this talk is also not about the pathways and the chemicals and the mechanisms. I'm part of the NIH psychedelic interest group. Um, go to many, many talks about the 5-HT2A receptors and the dopamine and adrenergic. And there was an article last week that showed that all psychedelics have overlapping interactions with the dopa, serotonin, and adrenergic pathways. So dopa is the reward system, famously depleted during Parkinson's, a kind of flat anhedonic stare, shuffling gait of a low dopa. Serotonin is a trickier one. It's kind of associated with pleasure, but not, but also like a state of being, of transcendence and happiness. And of course, adrenergic is, adrenaline, and that's excitation. So all of the psychedelics interact with all of those, and we're not going to go into the weeds there. Next page. There are two theories that I think help people understand, both fairly new and cutting edge, and quite different. So the first one is what's called the rebus theory. Robin Carhart Harris, both these people are now at Berkeley at the Psychedelic Studies program, but Robert and Carhart Harris came from London, and young, bright, very well spoken. Most of his work is with fMRIs, the imaging of the brain as it functions. And he called this the relaxed belief under psychedelics, bending the words a little bit, but the idea that your brain is more open. We'll talk about that with ketamine, because ketamine, I just was reading ketamine is like putting your phone on airplane mode. It just takes away a lot of the background noise from both your own brain and body and from the external. And this is a snow globe. There, Robin talks about the range of mountains now, and the idea being that we often have paths we go down, paths we take. This is the way we know, and the older we get more fixed in those paths, and most of them serve us very well. Occasionally, we get into a rut, and we know that when this memory comes up, we get depressed. When we think about, our ex-wife and the impacts of divorce, um, you know, it gets us into a space that gives us a rumination and gives us an obsessive nature of being in that rut. And one of the lines I like is getting out of the rut and into the groove. And the idea is recovering the mountains with 30 feet of snow so you can find new pathways down. That is a lot of what we believe psychedelics are doing. Of course, you have to be open to the snowstorm, and it's not for everybody. Next slide. So this is Goldolin, who's at MD, PhD at Berkeley now, came from the East Coast. She defined what's called the critical open period. So on the right are two graphs which compare on the top the acute effects of five different substances: ketamine, psilocybin, MDMA, LSD, and ibogaine. And on the bottom is the time during which the brain appears to be open to new learning. So if you think about critical open periods, think about a child learning a language or a musical instrument. They do it much better at 3, 4, or 5 than they do at 20 or 30 or 50. And what's been shown with all of the psychedelics, including ketamine, is that new synaptogenesis, new connections, new bends in the pathways in the way the brain works are possible for a period of time after psychedelics. And Gold really did some pioneering work, and these are her graphs. And I think it's just interesting to keep in mind that the brain does have neuroflexibility. And of course, when you look at syndromes like depression, we know that those connections get shortened and the dendrites get pruned and people involute. We've probably all dealt with a family member or someone who's depressed, and they feel like a withering plant sometimes. Well, psychedelics are an opportunity to sort of reopen the ends of those plants and allow growth if someone's open to it. Some people say rewire to refire. So how do you reprogram? How do you move forward? Next slide.
Yeah.
This is a lot about ketamine. I think the most interesting thing, ketamine was discovered in this early 70s, 60s actually. It was considered a buddy drug in Vietnam because if your buddy got his leg blown off and you had ketamine, you could just give him a nice shot of ketamine and then they could transport him and he wouldn't even feel or know that his leg had been blown off.
Wow.
Yeah, it's top 10 drugs for the WHO worldwide. It's used extensively in pediatric anesthesia. It has a lot of very good uses, which is why it was never classified as illegal and flew under the radar for many years. It works via NMDA. There's some stuff in there if you want, I can share, but it it has uses that were discovered after it was basically legalized. The pediatric anesthesiologists noticed that when kids were coming out of anesthesia, they would oftentimes have hallucinations. They would talk about kind of crazy things going on. And it didn't take long for somebody to try a little bit and figure out that actually that could be a pleasant effect if used at a lower dose. Ketamine, variously
Hmm.
known as Special K, or became somewhat of a party rave drug. And in low doses, it can be a um, kind of a mild anesthetic to the way other people view you or the way you self-criticize. And by opening that and allowing introspection of your own thought processes without the emotional overlay, psychotherapy takes on a new dimension. It does have indications for OCD, rumination, anxiety, chronic pain it can be used for, and then it's being used and probably abused in some settings. Matthew Perry, who famously died while on a massive dose of ketamine, several doctors went to jail, probably had 100 times the dose that we use in psychotherapy.
Cool.
So it's an anesthetic. He didn't breathe when he went underwater. It was not a surprise. But it's if somebody drove their car at 180 miles an hour, we wouldn't blame the car. So ketamine has been kind of pruned back. There were about 1,600 new ketamine clinics 2 years ago. That excitement has been dialed back a bit, but it still has quite an interesting use and abuse. And we'll talk about that. There is an abuse potential. Okay, next slide. So just a bit, I'm talking to the psychotherapy and the psychiatry department, but what is therapy? Right? And I don't, a large percent of America has, especially, educated, relatively well-to-do therapy, has at one time or another engaged in some kind of therapy. Basically, it's identifying difficult emotions, interactions, or patterns that interfere with our functioning in family, work, or social environments. Obviously, it varies in severity and the duration. We have all kinds of scores we can look at. Um, it's then taking those difficult emotions and using some form of a discussion therapy in a safe environment. Built relationship with usually a therapist, LMFT, PsyD, PhD, psychiatrist, family doctor, priest, rabbi, um, book club, and discussing some of the underlying events. Now, most book clubs aren't getting to your family of origin or your adverse childhood events, maybe to a little bit of the subconscious. But how do we use that discussion to get out of that rut, to get out of the stuck places? And we use skills, discussions. Christine is a DBT therapist, which uses a skill-based set of tools. So if somebody's ruminating and ruminating, the first step is to have them recognize they're ruminating. Do they want to be stuck in that pattern? When they're depressed, do they recognize I'm depressed? Oh, I need to get out. I should call a friend. I should ask for help. I should go do something I like. And if I'm freaking out with anxiety, can I take deep breaths? Can I take a walk? Can I exercise, play with my dog, call my grandkids, something? So, I put group work in there is also very powerful. And men's groups, John, you mentioned your book club, which I think every social gathering has some component of therapy for us. We know that gathering in groups is valuable. And of course, we often use medications, particularly from the Western lens of psychotherapy. So SSRIs, SNRIs, atypicals, antipsychotics, and even ECT, electric convulsive therapy, is used, which is kind of a hard reset of the brain, kind of turning off and turning on the computer. And it can be effective for particularly elderly with depression. My own bias is that we really should be thinking about ketamine before ECT, just because it's so much safer. Next slide. So, Western setting, and I use a psychiatrist, but a number of us are Western physicians, command and control. When I worked in the ER for a dozen years, you want to have a little discussion, but if somebody's coming in with a heart attack, you're not going to give them a lecture about, platelets and adhesion, and you're going to do what you need to do and move them to the cardiology suite or the ICU, right? We take control. And to a certain extent, psychiatry is better. They have a little more time, but it's often, especially when dealing with real deep psychopathology, it's take this drug, see you next week, and becomes a drug maintenance program. Um, it's efficient, it's directive, it's decisive, and in keeping with the IN words, it's insertive, it can be intrusive, and interventional. Next slide. So, two steps sort of away from that. The first one is more into the therapist setting. I'm going to say MFT, social worker. I would put rabbis and priests in with this, best friend, but the listener is more receptive, in tune with, using emotional mirroring. Wow, that sounds really tough. Tell me more. Was a famous early AI program that was intended to mirror psychotherapy and was seen as pretty effective for a lot of people because a lot of people don't have somebody who listens well. This system and this framework values connection, slower, longer sessions, 50-minute sessions, hour and a half sessions, um, more of the inner world and what comes intuitively. And the last line is a line I actually usually relate to psychedelic work, but working at the speed of trust. Because if you look at what makes a good therapist or what makes a good psychedelic guide, it's often someone you trust. You may even like the person and they like you. There's a mirroring that you want to reflect and improve. And in the doctor setting, some of those relate, but this is more of a consensual approach. Next slide. So, how do psychedelics differ from psychotherapy, and how does psychedelic psychotherapy and ketamine assisted CAP, ketamine assisted psychedelic therapy, differ? So, I didn't put some of the ads in, but I'm imagining most people have seen these ads for ketamine now, either on your Facebook feed or somewhere. But 10 years of therapy in 6 weeks. You know, I, and I will tell you the case, and Christine and I have had numerous cases, not every case, but many cases where somebody has been stuck in talk therapy for years. And then they do typically 3 kind of sessions of ketamine interspersed with integration and intention setting, and they get to a catharsis. They have an insight about their own behavior that they couldn't get to before. Ketamine is a shorter, a little milder. We're not talking about mushrooms or LSD, but it still has the potential to be a bit of a cobweb sweeper outer. Those parts of your brain that have gotten stuck. And we'll talk a little bit about death and dying, but of course our fear of death and the way we associate and medicalize and push to the hospital the dying process is quite problematic. And John and I have had, I'm thinking of Daniels, but several colleagues who, you know, we know that there are certain situations in which fighting a situation or fighting a cancer just makes our body a battlefield, and it doesn't always work out well. In fact, oftentimes, if you're 80 and you've got a lung cancer, it's you're going to cause more pain, or we've certainly seen that. But here's again, using this going in framework. This is before, during, and after. So before, what's a person's interest? How interested are they? And you could say it's a bias, but I won't work with people who aren't a 8 or 9 out of 10. If they're just a little curious, it's like, well, go read some more, talk to people. But, I'm going to set myself up for success by people who are truly interested. What's the indication? So classically, and we work, I'm not a prescriber for ketamine intentionally, but we use several psychiatrists, and they need to write major depression or treatment-resistant depression or obsessive compulsive disease. So there's some classic indications and there's some softer indications. Um, what's the intention? Is the intention of this person to just feel better? You know, just give me some opium. Just give me some Ativan. Just give me something to take away this pain. Or is there really an interest to go in to the environment inside and see what's going on, look at some of the root causes and the patterns, and see if you can change those? During a journey, which involves an ingestion and an inward looking introspection and an intimacy, into me see, into me see. So, how can I see myself? How can a therapist and how can a psychedelic substance, ketamine, help me understand my psyche? And ketamine works specifically as a dissociative anesthetic. It pulls out our thoughts from our feelings. And so there's a disengagement in the usual way we think, and it allows us to look and possibly re-engage in a different way. And that involves an intimacy and obviously having trust with the person you're working with. There is a saying in all psychedelic medicine to let the medicine lead you inward, even into your fears. So I was at a storytelling and a woman told a story of she'd had a recurring nightmare. Her whole family was on the beach and a huge wave was coming and it was just about to crash over her. And she would wake up in a sweat, panicked. And she'd had this for quite a while, several years. She did a mushroom journey and came to the realization that she had a new way she could think about this. A few nights later, she had the dream, and during the dream, she looked at everybody and said, "Run and jump into the wave, dive in." And everybody did, and everybody came up floating on the water behind. She never had the dream. It's a metaphor for one thing that's said in psychedelics, which is, and there's a Buddhist saying, let me get to it because yeah, the Buddhist saying is, there we go. Invite your demons to tea. See what you learn. Right? There's also a Nietzsche quote. There is more wisdom in your body than in your deepest philosophy. Psychedelics are a multidimensional fertilizer and a catalyzer. And the, it involves an art as much of medicine does and much of life does. But letting the medicine lead and being a guide to that lead. And I think Dan will talk about that in his case specifically. But then the work begins. Famously, Timothy Leary said, after the trip, then the real work begins. So afterward, there's integration, innovation, and you in the future. So integration can occur on many levels: intellectual, emotional, somatic, spiritual, or play? And I think of play, and I came to a famous Shakespeare quote out of Hamlet. The play is the thing wherein I'll catch the conscience of the king. Act two, scene two. Um, where he's using a play to tell the story to his uncle who killed his father to get his mother's hand, the queen. I think that I'm sure we have some Shakespeare, but movement, dance, yoga, tai chi, you know, there have been therapies, scream therapy famously, or, EMDR, moving things across the two halves of the cerebellum. Uh, Psychedelics is multimodal, and good healing involves many of these opportunities for learning. Um, uh, yeah, the other piece that plays on this is, I have a couple of pictures, I think, from Jung and the Red Book, but Jung and Freud kind of rediscovered the subconscious. And so how much that plays into what's going on is um, tricky to put out in words. Next slide, John. Oh, here's the young. Yeah, here's the dragon underneath the boat and the balance of life and the fire breathing. And so just, this is not new. And of course, it goes back much farther into, I think, Plato and Aristotle, but was famously sort of rebranded in the 1870s and 80s and 90s. Next slide. A little bit about the setting for the environment, and I do want to get to the cases, but a safe space, right? Dream space. Think about having, if anybody's done lucid dreaming or woken up with a dream that was a more of a nightmare, have they ever gone back into the dream? Because that's what lucid dreaming is going back into that dream to confront what came up. But how do you connect to your higher self? How do you trust in the good? The Jungian archetypes, right? The hero's journey. Um, Christine uses a lot of visualization. She wants people to have a safe space, so she'll really anchor people into a safe space. And then eye shades on the couch, music with headphones or a speaker, and letting somebody journey. In the case of ketamine, it's half an hour. It's not an incredibly long period, but we really encourage people to get out of the talk, thought, headspace, feel the disconnection, and look at things. And then as they come down off of the psycholytic dose, we journal, we work with people, we give them tools, and we send them home. Go journal for 30 minutes a day for the next 4 days. And then we'll see you in integration across that. Touch, weighted sandbags, whatever you want people to feel safe. Next slide. So, illustrative case. Steve's a 46-year-old man that was referred to me, and then he was referred to me for mushrooms, and I thought that he wasn't quite ready for mushrooms, and he didn't necessarily need them. And I sent him on to. We met with Christine, and she has done ketamine with him. He's been in talk therapy for years. Ruminates a lot of things, gets stuck in anxiety, lives with a fear of failure. Although he's functionally doing well, he has a couple young children. He's a teacher. He functions, but he wanted to see if he could get out of this space he was in. Been on SSRIs, a couple drugs, and he was referred to us at the DBT center. So some preparation, intention, talk about the inner work. It's setting somebody up, as somebody said, you're going to be flying in an airplane and you're not going to crash, but there might be times that are a little scary, but we'll be right there and it'll be over in, it may seem like hours, but it'll be over fairly quickly and it'll be over fairly easily. So be okay with whatever comes up. So classically, ketamine kind of either works or doesn't. Journey J1 was the first journey. We use a sublingual dose. People use IV, IM. You can give it a lot of ways, but a sublingual dose allows a 10 or 15 minute settling in period during which Christine usually reads some incantations and thoughts and goes back over someone's intention and keeps them comfortable. His first journey, as with many people's first journey, is just getting used to flying, getting used to the space. And we gave him 100 milligrams, and he walked away unimpressed. He didn't really feel that much, and he wasn't even sure about the next journey. Because sometimes we say, do one and see. And, it's 3.5 hours of Christina's time. It's somewhere between $750 and $900. So it's not cheap. But he called her 3 days later and said the cloud he'd felt over him for the last 3 years had disappeared that afternoon. He felt a substantial shift in the way his world felt. And he said, I want to do the second journey. Going along with that croak open theory, ketamine has a very short period. So it has a couple days of integration and openness. And some people do 2 journeys in a week. Some people do a journey week over 3 weeks. We kind of spaced it out a little more. But his second journey was a couple weeks later with 200 milligrams, double the dose. And he had somewhat of a dysphoric journey. He definitely felt it. He was aware of some monsters under the bed, was his word. And he felt somewhat shaken, somewhat kind of um, not alarmed, but he needed to process it. Um, he did process it, and in keeping with the, sort of diving back in, did come back to us. I'm just looking at the time. We're fine. And his third journey was actually quite successful. He uncovered a pattern of incest in his family that he hadn't talked to anybody about, got tearful. His cousin wasn't sure if her father was her father or her grandfather. Nobody had really talked about it. A lot of this stuff came out, and he felt a, a lightening, kind of a, a lightening of his mood and an ability to let this off of his chest. Talked to his wife who'd been involved, and did integration. Christine likes to do a lot of prep and integration. So this was a client who we had met with 3 times before the first journey, then usually at least 1 or 2 meetings between the journeys, and then he wanted to do a fourth journey of quite a high dose just to see what it was like. He did. It was much more of a psychedelic trip. It just cemented. It didn't really give him any new insights, but and we have our final meeting. Because I handed them to Christine. They've done this work. I've heard about it, but I'm coming back in, I think, in 2 weeks. So that was the case. Now, I do want to preface this with not everybody likes ketamine, and it's not good for everybody. But we know that SSRIs help half the people some of the time. If anybody's been on them, you're often on them for years and years. They can help, but they're not addressing underlying events. Next slide. I think I'm going to hand this to Dan.
Thank you. Thank you, Pepper. Yeah, so this is a case of a woman who was 87 years old. I had known her, she had been a congregant in my community for 20 years. Got to know her very well, did a lot of work with her. Um, and she had a profound fear of death, much greater than the normal existential fear of death. She didn't want to talk about it. When her husband died, she couldn't go to funerals, even her husband's funeral. It was just it put her in a state of absolute terror. Um, Ironically, or the place that she was very comfortable was the hospital, because in the hospital she could fully relax and she was taken care of, and she She went into the hospital for all sorts of things over the many years that I knew her. Um, she had end stage cancer, and she went into the hospital. No matter, all the work we had done, it didn't seem to mitigate the intensity of her fear. Um, and she asked me, what can I do? And I said, well, I have worked with people, and I need to say this, that um, many people have come to me to do psychedelics at the end of life. And in a vast majority of the cases, it's too late. It's too late to even consider it because people are on multiple medications and there's complexities and there's so many issues that we just can't, it just doesn't really work to even try. But in this case, I said to her, well, um, I suggested a ketamine lozenge, and I said, I'm not promising anything, but I think, it might help. And we had, I talked with her at great length about the ketamine, what it does, and told her it would be a relatively short experience. And I didn't think there was, she talked to her doctors, and they said, sure, why not? Um, so we did, she ingested a lozenge, and um, I sat with her. Um, she had an experience in which she felt that she was a consciousness floating in the cosmos. And I told her that she might have an experience that felt like she was dying. And I said, when you have that experience, please know that you're not dying, that you're on this journey. And remember that. When you experience that fear, remember that. And she thankfully did. And what she came through the experience, she was really out of the intensity of the experience in about 45 minutes. Um, and she had this remarkable expression on her face. And I said to her, how was it? Is there, you want to talk about the experience? And she told me that she had experienced what it was like to die in her opinion, and that it was a very calming experience. And she, uh, I've worked with a lot of people around preparing them for end of life, and this was the person who had the most heightened sense of fear, and she did the most remarkable emotional pirouette I've ever witnessed.
Wow.
She simply said, I'm ready. She couldn't even talk about death in a conceptual way. And after this one experience, something profound had shifted in her. And she said, people who came into the room, her daughters, adult daughters, both of whom were in their 60s, late 60s, said, what happened? What happened? She has this lightness to her being and this aura. They use the term aura that
Ketamine.
she's never had before. And I said, well, it wasn't for me to divulge what she had done. That was for her. But I said, we've been doing a lot of work, and I think she's come to terms with her own death, and she moved to her death with equanimity, and it shocked everyone who knew her. And it certainly was an enormous surprise to me. And but she was filled with such gratitude, and there was such an easing of her burden, a burden that she'd carried most of her life, and she was able to die calmly. She said goodbye to her daughters after she had lost her swallow reflex, and she knew her systems were shutting down. Nothing, it didn't bother her. She said, "I'm ready," and
Wow.
she moved into her dying and died very peacefully. So that was it's not something I don't share this as if this is magic and that this will happen for everyone. I know that it won't, but for her, it allowed her to release something, to come to terms with this profound irrational fear, much more so than, it's the end of me. It was something very deep and very powerful, and it changed the way she left this plane of existence.
Great. Thanks, Dan.
Sure.
Um, let's just go. I want to have some time for discussion. I've got a couple more slides. The next slide is just two quick cases, and Dan alluded to this. This is a relatively young man who was diagnosed with an aggressive lung cancer. And it raises the question of when someone might want to be interested in psychedelics. And I think Dan and I would pretty much be in agreement that saying, don't wait till I mean, we know hospice is like 10 days before people die. So waiting for hospice is way too long. Age 60 and healthy may be too young, but um, it's an interesting tool to know about. I referenced to Atul Gawande's book, Being Mortal, about his father's diagnosis. And then the last case, just of a case that didn't work well at all. This was a younger man who was a security IT, very high functioning, stressed about life, but he really wanted to know if ketamine could help unlock him. And um, whether we didn't prep him well enough, we didn't create a safe enough environment, or he just was not going to divulge or open, he did one journey and said, "Nope, not for me." And there's other people who have dysphoric reactions. There's classically what's called the K hole, which is when somebody goes in so deep they get scared and they have a near-death experience. That usually happens at a rave or a party or someplace that's not a safe environment, but it happens. And then I think the last one, or I got a couple more slides, contraindications. Current psychosis, delusions, or mania, obviously they can't consent. Severe incapacitation, severe anger, unstable personalities. Christine works with a lot of borderline personalities, and she's reticent to work with people until they really have skills. Very high blood pressure, sleep apnea, or medical conditions. Relative, personal history of depression or mania, although it's also used for depression. So, that's, you know, careful. Family history of mania, poorly controlled diabetes, hypertension, or other diseases. And then cardiac is really more with the classic 5-HT2 serotonin. There's been some concern about valvular disease, not with a single dose. This is more with microdosing and long-term use. Ketamine can cause bladder problems, particularly if used long-term, and they can be problematic. And then we mentioned addiction and thinking about the Matthew Perry story. It can be an addictive substance. As with any substance, are you using it to escape or are you using it to investigate? I think last slide, just risky uses. Yeah, I would mention that. But what are we facing? A narcotic epidemic that 80,000 Americans are dying. 10 vets are committing suicide a day, and ketamine, one of ketamine's indications is suicidality. It's very effective in the short term. It's not clear if it's as effective in the long term, and it's not clear if it's effective without psychotherapy. But and then yearly substances use is killing a lot of people. So it's always a balance. And then the last slide is a little bit about ethics. Just, how do we as clinicians safely and ethically use and recommend these compounds? Who should be holding the reins? I did a year of post-training. Dan and I have both been involved with psychedelic use for many years personally, and in well-held communities. But, you know, should any anesthesiologist who has given ketamine in the OR be okay to give it in the clinic? That's what a lot of these clinics are, is just sort of hooking people up and giving them the medicine without any guiding. Who should guide? Who shepherd? And who sit? Who should prescribe? And then maybe the final question, um, do you have to have experience with psychedelics to both understand and effectively use them? And many of us would say that yes. And having done this, I now think that we should give all medical students 100 milligrams of Seroquel once, 5 milligrams of Valium once, and 50 milligrams of or 10 milligrams of Paxil, just to help people understand kind of what you're doing, because we don't really. Um, the last one is just some suggestions and considerations. Sorry, one more slide, and then we're to questions, John. Um, the medical model pathologizes so much, treatment resistant depression, you're a treatment failure, in end of life, don't give up, how much of that's driven by the system, big pharma, you know, cap is expensive. I think the course for the first case I told you about probably was around $5,000. Now, mind you, that's a year of Zoloft. So it's kind of all relative. The pharmaceutical industry doesn't make much money. Ketamine is pennies. If you put in a nasal spray and reformulate it, they can charge $700. But so who's driving it? Um, how do you metabolize scary things? And going from scared to sacred. The image on the right there is from an artist at in San Francisco. Um, And then I think the last one is just questions, thoughts, and discussion. I would love, sorry we didn't leave a lot of time, but I would be curious about people's thoughts and reflections.
I'd like to know about long-term studies.
hmm With ketamine? Well, ketamine was just approved for depression in 2020. So it's a relative, we don't have a lot of long-term studies. There are concerns that it's quite good for the short term, and we don't know as much about the long term. It's a good question. Um, stay tuned. I would say there are lots of different treatment protocols. Some people do use ketamine. I mean, our hope in using it is that people go through a initial induction and then maybe once every 3 to 6 months need a tune-up. There are people who feel like, and you can go to Mind Bloom and they'll give you a microdose and you can take it every day for the next 5 years. I have my concerns about that in terms of the model, but also the side effect profile. But my hope is that we're helping people really understand more of their subterranean groundwork and their fears and their shames and their angers, and that is more transformative than placating.
Shigeko.
I was one. Oh, um, I was wondering, are there any side effects to this treatment that you've noticed?
Mm, um, Sometimes happiness and wow and amazement. Um,
No
okay,
adverse reactions?
yeah, there are people who don't like it.
Uh,
People who feel a dysphoria and a loss of control and either haven't been briefed well or just don't like being out of control.
mm,
Um, in low doses, which is more the psycholytic as opposed to the psychedelic range, most studies show a very low rate of what we would call serious complications. There have been like 500 studies since 2000 on depression. None have found, you know, extreme bad events. Matthew Perry was not a treatment protocol; he was a abuse protocol. Um, so the big it doesn't, as Dan mentioned, it doesn't interact with many other drugs, and really has an incredibly good safety protocol. I'd say the biggest pieces are maybe the psychological. Dan, you want to add to that?
Yeah, I think that it's it's a drug that there's a lot of abuse among young people, especially because it's easy to obtain and it's very addictive. And the addictive part of it is a great danger. But I think that, when it is when the precautions and the care is taken that Pepper talked about in terms of set and setting and safety. I was involved with a group that administered IM ketamine to several cohorts of mm, doctors, clergy folks, chaplains, end of life doulas, many of whom were going to be expected to be working with people at end of life who might want ketamine. And the feeling was is that they should experience it themselves so that they would be able to provide a better form of care for their patients, for their clients. And I mean, the response was quite, across the board. I think we did three cohorts of about 7 or 8 people, and none of these people had ever done ketamine before. And their reports were profound, and many of them some of them just had some really wonderful visual and dissociative experiences, but a lot of them got into some very deep work, and things were dislodged, and there were um, there were insights that they were very grateful for. So again, you have to think about the setting, and it is absolutely critical, and before the preparation, like with any psychedelic, the preparation and the integration is absolutely essential. And to have that kind of follow up and care and attention, um, I don't think there is such a thing as a bad trip. I think there are challenging experiences that, if processed appropriately, can be incredibly fruitful, although they might be experienced as very difficult during the journey itself.
I have a question. Are there any limitations that governments have placed on it? State, federal, other states? Can you do this in all states?
Yeah, it's federally legal. It's a class three drug, so it's no different from Paxil or Prozac.
You need a prescription.
You need a prescription. Yeah, you need a prescription. And there have been supply issues because it is so cheap. I mean, literally, you could buy a vial of what was effectively like 50 doses for like $100
Of ketamine.
and of ketamine. Yeah. And the producers reformulated it to be a nasal spray that's, $700 a dose, and they like that a lot more. So it's harder to get the vials. I think there's been some clamping down. There have been some raids of ketamine IV infusion clinics where the feds have come in. But a friend of mine had one of those. They kept good records. They had the safe with the ketamine in it. They had, they weren't diverting it. That's the concern. And a lot of the diversion in Matthew Perry. That's the concern. But there's no federal restriction right now. And there's no state restrictions that I'm aware of. Even in the backlash of Matthew Perry, there was a caution, but not a clamping down. It's got too many good uses, John, and it's too broadly used. So, Michael,
Has it been used in traumatic brain injury, so-called post-concussion syndrome, people with all kinds of issues, headaches, depression.
Yeah,
Uh,
well, it's been a lot of headaches, cluster headaches, famously, or ergotamines, and LSD has been very 2-bromo LSD has been very efficacious. And ketamine is being Phil Wolfson, who's in Marin County and wrote the book The Ketamine Papers, is currently involved in a study with closed head injury. And Gold Dolan is involved in a post-stroke study where they're looking at neuroplasticity to see if it can help with new brain growth. Good questions, and because it's not an expensive drug and pharma doesn't make a lot of money in it, there isn't the impetus to do the studies. So you either need the NIH or some somebody who wants to throw $10 million, but those studies are, as you well know, very expensive. But good question. Thank you.
I have one other question because I'm curious, the so-called hormonal basis for things like postpartum depression and postpartum psychosis, which people say, well, there's got to be something hormonal going on. Has it ever been tried in those
Yeah, I was
instances?
just yeah. Psilocybin has been. It's in a current study in Colorado right now. Postpartum. There's an OB-GYN there who's been using it quite successfully. I don't know if ketamine specifically has been looked at. Do you, Dan? Do you know anything about that?
No, I haven't read anything about it. I haven't seen anything about it.
Yeah.
Yeah, there are tests going on at standalone uh, hospice facilities around the country using ketamine at end of life, and the results are not yet in.
Yeah. Yeah. We have colleagues who've been involved in that.
Oh.
I go. Oop, you're muted.
Muted.
Yeah, okay. Um, are your patients mostly middle-aged or are they older? Or what is the age? Is there
Uh, Mostly middle to older.
uh
Um,
and the middle-aged people that have these problems, is it real traumatic life problems that have, caused these anxieties or obsessions or whatever you want to call
So
it?
I referred to the ACE, the adverse childhood events. A lot of press these days about trauma, repressed trauma, early trauma, worse if it's younger. Um, Unburying that trauma is not trivial. And rating it and grading it and doing the randomized control trial. Let's find 100 women who were all raped before the age of 15 and let's randomize them to this trial. I mean, you can see that it'd be an incredibly difficult study to do. You're dealing with the human psyche. So, um, Dan and I are, and Dan's wife is a death doula. And with Christine, the four of us, we're more focused on helping people who aren't quite as severely afflicted or who are dealing with dying. And I would say my you know target audience is educated 60 to 80-year-old people who aren't actively dying, but are beginning to think about it. I have a case now who's he has fairly advanced Parkinson's and came to me for psilocybin therapy because psilocybin is decriminalized here in Oakland. And there is a UCSF clinical trials on psilocybin and Parkinson's that appears to be quite effective. Now he probably has, several years till he gets to the point that he can't feed himself or, faces even tougher decisions. But having people have some quality of life and time left to me is always beneficial. If we can impact people earlier, I think I don't know, Dan, you got thoughts on that?
No, I think we're on the same page. I have worked with people who have in a ketamine journey discovered that that there was sexual abuse, and because in the experience, the fear tends to be um, minimized. It allows for an exploration of trauma, I think, in a very different way than in just regular talk therapy. And I think that's part of its efficacy.
Yeah, we aren't discussing, but MDMA, an pathogen that really opens people's hearts. Uh, Advanced practitioners, us included, are starting to look at the combinations where you can bring somebody gently into a space and then allow them to really have an insight and then settle out of it. It's complex work, to say the least. And it's so varied that it's really challenging to say, every 70-year-old who has this diagnosis should do this medicine because it's just such a wide spectrum. You know,
Have you ever studied hypnosis?
Hypnosis, I don't know much about that.
Have you ever seen any studies on the use of hypnosis with the kind of clients or patients that you're talking about?
I've read that I don't know that literature terribly well. I know there's some interesting work done with hypnosis where people can uncover some difficult things that are lying down there. I don't really know much about it. I don't know if anybody else does.
And what's the number of studies that have been done? How long has this been done and the number of cases?
Right. Well, I just read a review paper since 2000 when, sorry, since 2020,
Yeah.
ketamine came out as the spray, Spravato. There have been 500 research studies and I think, thousands of cases. And it's maintained. Part of the reason there has been a clampdown is because it has been so effective, particularly in deep depression, treatment-resistant depression, and suicidality. Your question about does that hold for 5 or 10 or 20 years remains relevant, but we just don't have those studies yet.
I saw a study where 40% of the people who were um, SRI resistant did ketamine had it had a significant impact.
Yeah.
I don't know, that's some indication. I mean, the reality is that at many hospitals, if you go into surgery, you can elect ketamine over regular anesthesia. Doctors aren't don't tend to be so supportive or willing to offer this because they don't want their patients to be conscious during surgery. But people who have done that have had, come out of the surgery without the all of the associated problems with anesthesia. You don't have that with ketamine.
Right, the deep grog,
Yeah.
yeah, it's a very effective anesthetic and can be used yeah,
And it,
people use it a lot. It doesn't depress blood pressure or heart rate, and it's got a clean aftertaste or afterglow.
you can if you do a ketamine journey an hour and a half, 2 hours after the journey, you can drive home with no concerns. You are fully sober and in control of your faculties.
Yeah.
So that's
Christine likes people to have a driver, but she's incredibly cautious.
yeah.
But yes, it's true. It's got a very clean, couple hours later, you know.
There's very little what's called body load, very little impact on the heaviness, the sort of after effect that some sacred medicines leave you with is typically very minimized in ketamine.
Yeah, I think part of what Christine really likes is she likes somebody to stay in kind of that slightly altered space and that openness, so you just don't jump right back into your life. You actually, pull back a little bit and examine. So she typically will encourage people to take the rest of the day off, maybe go to the park, the cemetery up the block from her. Uh,
Journal.
Journal is great. Something that opens your mind and your heart, because while it's not an MDMA heart opener, it still allows, as you said, sort of that disconnection from the head and the emotions, which can allow for insights that are very unique. And you probably have a couple days of that psychological afterglow, but virtually no impairment with functioning.
One of my teachers said, the journey doesn't end when the journey ends. So, and
Mm.
the most valued part of these experiences is the integration. The
Yep.
longer you can stay in it, the longer you can pay attention to what's been stirred up and um, what you've been invited to look at, then that's the value of this experience, as far as I'm concerned.
Yeah. Yeah. And just I'll let John know, but Dan and his wife are doing, kind of ramping up as his refirement, the Ariel Jewish Healing Center. And so I think you're going to be based over here in Rockridge eventually. And they do grief groups and a number of associated healings, not all necessary, or many actually not related to ketamine or psychedelics at all. But it's a process that, I'm one of the younger members of the group, at 65, and we're all getting there.
Yes, we are.
Yeah.
Well, thanks, guys.
Yeah, thank you.
This has been really great. Dan, it's nice to meet you, and we'll stay in touch, and that's great. And any other questions? Otherwise, I'll stop recording. You can stay on if you have something to say that you don't want recorded.
Thanks. Yeah, and actually, go ahead and start.